Well, I'm so glad to see so many people here. It's exciting for me to present because we are now a baby-friendly facility, and it's very exciting. So my name is Kathy Parks. I am the lactation consultant at Christus Santa Rosa in New Braunfels, Texas, which is just outside of San Antonio. And I'm not getting the forward of the slide here. Okay, can you go ahead and forward it to the next slide, please? So we are located about 30 miles north of San Antonio. The original hospital was built in 1953. It was McKenna Health, a small nonprofit facility. In 2008, the Christus Corporation purchased McKenna, and it became Christus Santa Rosa New Braunfels. It is still a nonprofit Catholic-based hospital. We have 7 LDRs and 9 private postpartum rooms. Our birthing rate has dropped over the years, but it's currently about 850 to 900 births per year. We had 2 FTEs for IBCLCs, and in 2015 that dropped to 1 because of our lower census, and they maintained my position as an RN IBCLC. We do have a level 2 NICU with 6 beds, which is a part of our children's hospital in San Antonio, which is a huge NICU, 45 beds and a level 3 plus. So we can take care of, at our facility, we can take care of babies 32 weeks and up unless they're on a vent. And then they would be shipped down into San Antonio. Okay, next slide. So we began the baby-friendly work all the way back in 2005 as the first hospital in the Christus Corporation to even look at it. This was a huge, groundbreaking move. We started with just keeping the time in the nursery to a minimum. We had a separate nursery, a large number of private practice pediatricians who had privileges at the hospital. They didn't want to do any exams in the rooms. That was just not something that they were even open to. So our babies following delivery, whether it was a normal vaginal birth or a surgical delivery, went immediately to the nursery. Just keeping them in the nursery for a short period of time was an effort that was Herculean at the time. In 2010, we closed that nursery. It became our level 2 NICU. We're kind of landlocked in our hospital space. So we didn't have another location to start the NICU, so it was a logical move to go ahead and do that. We entered the development stage of Baby Friendly in November of 2012. You can see that's 7 years of work to even get to the development stage. Not quite a year later, we hit the dissemination phase. And again, just a little over a year later into designation. We received our designation in September of last year. We are the first baby-friendly hospital in Central to South Texas. That is a huge feat because it's a large number of hospitals. We had an initial CHAMP. In fact, we've had several CHAMP surveys, but our initial BFHI site assessment was in November of 2015, and we were dinged on a couple of things, not what we had expected. It had more to do with patient recall, and at that time, they were calling patients, if we didn't have an in-house census, all the way back to 6 months post-delivery. And of course, those patients didn't remember how much time they spent in skin to skin. They didn't remember if we showed them how to hand express. It was just too long to recall that information. So we failed that one. In August of 2016, we had our final site assessment and then the designation following that. We really concentrated on the areas that we felt were weak, and it was not what we had expected. It was not administration. It was not the physicians. It was staff teaching of hand expression and patient recall. So next slide. In 2009, just before we entered the baby-friendly pathway, we had an 88.5% initiation and any breastfeeding during the hospital stay, but a 79% exclusive breastfeeding at discharge. So even before baby-friendly, we had worked on getting the stats up. We had no skin-to-skin care after birth, none, and that was a huge feat in itself. By this year, we are at 100% any breastfeeding in the hospital, 93.5% exclusive breastfeeding at discharge, and an 83, almost 84% safe skin-to-skin care after any birth. That includes both vag and surgical. And many of our preterm, late preterm babies, twins, go to skin for their initial assessment. Next slide. To fund the project, the Baby Friendly Project, we started in 2013 with our first annual Harleys and Habits. Now, I own a bike with a sidecar. We have nuns in the hospital who've never ridden a motorcycle before, and this was a huge way to raise funds because we're right on the edge of the Texas Hill Country, which is a very popular site for motorcycle rides. The nuns decked out in their full habits, and we put them on bikes, and most of them rode the bikes all through that complete 4-hour trip. They didn't want to get off. We raised approximately $25,000. That funded the entire baby-friendly initiative. We had our second annual, which raised almost $30,000 in 2014. So that helped us to be able to work with administration and the people that were counting pennies, because we are a nonprofit, to be able to justify what we were doing. Now, if you're going to do something like that, any kind of fundraising, make sure that money is earmarked for the baby-friendly process. That second, almost $30,000, went to a whole bunch of different programs because everybody saw how successful it was and what we want a piece of that pie. So all of that didn't go to baby-friendly that second time around, and I wish we had foreseen what would happen there and really just completely earmarked that funding. The other helpful hint is to get community involvement. By doing something like Harleys and Habits, we had lots of community involvement in the way of sponsorships, in the way of just people coming out to watch this. New Braunfels is a quaint little German town, and with a town circle, and we would go through the town with the nuns on the bikes or in the sidecars, and people were just drawn to that. So it was a huge way to get community involvement, get the word out. Next slide. Finally, after 7 years of hard work, we got our designation. So you can't see that picture very well, but you'll see it in the next slide. We were the first baby-friendly hospital in Central to South Texas. That means there's none in Austin, none in Corpus, none in San Antonio. We were the first. We're only the 18th in the whole state. The majority of the baby-friendly hospitals in Texas are in the North Dallas, Fort Worth area, with several in Houston and several in El Paso. Other than that, it's not spread out through the entire state, and I think that's something that's going to be changing, but it does take time. Next slide. There it is. It's a picture is a very famous painting. And when we had that painting awarded to us and hung with the baby-friendly designation, the nursing staff all came to me and said, that is the worst positioning ever. So it was just, for me, it was a reinforcement that the staff at the hospital knew what they were doing. And the 2 CHAMPS mock surveys that we had were extremely helpful in pointing out little things that needed to be changed. You know, I had the foresight to see the big things, but the little things were really what made all the difference in the world. We did have physician resistance. We only have, even at this point in time, 1 physician who is actually hired by the hospital. The rest are on contract. So by definition of baby-friendly, they weren't mandated to take the training to get on board with the program. And we do have several that are completely resistant to that. The rest of them, though, through the years have actually come onto the baby-friendly process, are really seeing by results how it changes the breastfeeding initiation and duration rates for their patients. In fact, when we had our second site assessment visit, I had physicians volunteering to come in to be interviewed at that assessment. For me, that was a very good sign, and it did make the difference. They really got kudos in the assessment results that we received. Next slide. So here's a couple of things that I found were extremely helpful. One that's not on here is to remember that your site assessors will not share any of their results with you. You cannot tell whether you passed or not by what they say or do at the time that they leave. It is a 2-day assessment. Our reassessment visit was only 1 day, and they were only checking the things that had been caught during the first one. You want to make sure you have 1 very knowledgeable staff for each assessor. Usually there are 2. That staff person needs to know the process inside and out. They need to know how to get to patient charts, even if they've gone into an archive status, how to be able to get to those charts, because they will be checking charting. They will be checking a duration of skin to skin. You need to make sure you're charting all of that. You want to provide patient teaching in all formats for adult learning. When we got dinged on that the first time, we put together some teaching notebooks in addition to the regular teaching that patients get, but it was specific to the size of the baby's stomach, the amount of milk that they actually need in that first few days, the hand expression, English and in Spanish. We have a large Latina population in our area. The use of skin to skin, you know, how important that is, not just following delivery, but at least for the 4th trimester, that first 3 months after delivery. All of those things with lots of pictures so that people could look at the pictures, read the text, actually do those things. We make sure they're very well versed in each of those steps before they leave the hospital. And so being able to provide that with a little bit of information. You can't say, well, the baby-friendly assessors are going to call you and ask you these. But, you know, here are some things that you might remember if you get a phone call. I wrote up cheat sheets for staff, for physicians, and for the administration. The administration were interviewed at both assessment visits. The physicians were interviewed at both, and then, of course, the staff. So for the months ahead of any assessment visit, I put together, here's the important things to remember. Why is breastfeeding important? Not just it's good for the baby's health, but you need specifics in there. Have everything very well organized. This is where you want to be OCD to the max. One of the CHAMPS people, and she knows who she is, sent a suggestion for notebooks. So I took that and I made multiple notebooks, one specifically for the staff education. So we used step 2 education for ours because we vetted all the different things out there, felt that that was the highest quality. So we had a complete rundown of everything that's covered in the staff education, all their certificates, the 5 hours hands-on, all those learning goals and objectives. We had a notebook for each one of the extra staff, so physicians, unit clerks, cleaning people, all those other allied professionals. We had a notebook for them in the education. We had a notebook for policies, procedures, everything that had to be accessed. We had a notebook for anything else that might come into play. So any teaching that's done in the prenatal classes, we had a copy of all of that. So anything that would be helpful for the assessors was put into a notebook with easy access and an index in each one. Okay, you want to make sure that you have rooms set aside for the assessments to take place. They need baby dolls, they need breasts to practice with, they need, I included a formula teaching kit, which we do, of course, one-on-one with any mom who might be giving powdered infant formula after discharge. And so I have a demonstration kit that I put together. And you want that room to be accessible to the area that the staff normally works in, so it's quick. If they're on duty that day, it's a quick go in, be interviewed for 30 minutes, and come right back out and go back to work. If you need to have patient contacts that need to be made by phone call, you need to make sure you have at least double the recommended number. And you want to call those patients ahead of time, not to say, this is exactly what you need to say. Don't coach them, but tell them that they may be receiving a phone call on this date between these hours, and remember that teaching we did in the hospital. And then if you're the person in charge of this program, you want to take the next day off and take care of yourself, because this is extremely stressful. And I know for me, that was like take the day off, go outside, in the garden, pull weeds, whatever I needed to do, and don't second guess yourself, because this is a tough thing to do, and we pay to do it, which is even better. So be sure you take really good care of yourself. And I think that's my last slide. There you go. So our next steps, once you get the designation, you're not done. You have annual QI projects that need to be done. We're in the middle of trying to take our NICU to baby-friendly status, so that DOBFI, and the guidelines are just coming out for that. Our staff education and hands-on practice is ongoing day to day. And then, of course, any new associate that comes in spends 8 hours with me before they go to work by themselves on the unit. Our other thing, and I know Jennifer White is here, we are assisting the other San Antonio Christus campuses in their baby-friendly pathway. And Jennifer works at Children's Hospital of San Antonio, and they are right there. They will soon have their designation visit. So I am rooting them on. Probably the best piece of advice that I would have for you is don't rest on your laurels. Don't quit just because you get that designation or you've had that site assessment. You've got to keep up with this, because you have to recertify or redesignate at the 5-year point anyway. So don't quit. And I will mute myself for Antoinette's presentation, and then I'll unmute at the end for questions.
All right, thank you, Kathy. We will pass it on to Antoinette so she can get started.
Thank you. And let's see. And I don't have the advanced slides either.
Oh,
Rebecca.
So weird. I can advance it for you.
Okay, great. Thank you. Hi, everyone. First off, I am Antoinette Kleiner. I'm calling in today from Shiprock, New Mexico, which is out in the northwestern corner of New Mexico near the Four States Monument. I'm happy to be here with you today and excited to see so many people on the call today, on the webinar today. I just want to give a shout out, congratulations to Kathy and the team there at Christus for that incredible work. It is a huge undertaking that you are all on. And one of the things that struck me in listening to Kathy is just how different our hospitals can be and our journeys may seem. And it's easy to feel isolated, like you may be the only one going through it, but there are really so many similarities in what's going on, and there are a lot of people to help you along the way. Our hospital here in Shiprock is part of the Indian Health Service, and that's a national organization. We're typically in very rural places across the country. Our hospital delivery rates at this point are around 400 to 450 deliveries a year. Excuse me. And as the Indian Health Service model is, we have everything pretty much under one roof. So we are our own prenatal clinic, we have our own pediatric clinic, we have our inpatient obstetric care, and then we have our own public health division that provides a real continuity of care for us. And in that manner, our journey is a little bit different. The things that Baby Friendly came and assessed us on were slightly different because we have slightly different services. Our physicians, unlike what Kathy has experienced, our physicians are actually employed. They get their paycheck just like the rest of us, signed by the same person. So in that way, we were able to use that as part of, the expectations of their job. So it was very helpful. And before I kind of move on into the rest of my presentation, I wanted to just concur with Kathy's comment about taking that next day off. I remember wishing I had. And really nearly calling in the next day because it is a worthwhile journey, but it is very stressful. It is a lot going on, and being able to just decompress after that was a very helpful thing. So with that, I'll go ahead and move in. If you would advance that slide for me, please, Rebecca. Thank you. So the Indian Health Service, like I said, is national. And we really began breastfeeding support and traditions, keeping those traditions alive. We're trying to, decades ago. This work has been ongoing. I have coworkers here that have been working on breastfeeding support for 30 years. And it wasn't until about 2011 that we actually launched as an IHS service the Baby Friendly Initiative. And we were mandated as part of the Let's Move campaign and Michelle Obama's campaign to reduce childhood obesity. We were mandated for all of the Indian Health Services hospitals to become baby-friendly designated. And we were given, a pretty quick timeline. The goal was to have us all designated by 2014. We really started off in 2011, 2012 with some very standardized approaches. We were trying to, make sure that everything seemed pretty similar across IHS sites. And we really were trying to combine that effort with the local grassroots work that was going on. Like Kathy and Christus, we did not pass our first site visit in 2013. And like she said, it wasn't the things we were thinking we were the weakest on, such as physician resistance and, lack of administrative or executive support. it was patient recall, and it was our documentation. And we thought we had those things pretty tightened up. So it was quite disappointing to begin when we got that assessment result. And then we took that really into a beautiful learning opportunity. And I had one of the physicians who just kept telling us, you know, that actually turned out to be one of the better things for us. It really helped us at the entry level own our baby-friendly effort, whereas before some people felt like it was more of a mandate and they just had to go through the check boxes. The second time around, it really felt like they took part of the process and they owned it. So in 2014 of March, we had our second site assessment and we were designated as baby-friendly. And we've really continued to keep that those efforts going. And our picture there on the right side of your screen is the twins that were part of our second assessment that actually went on to breastfeed for, I believe, 18 months. So they were a beautiful part in helping us get that designation. Next slide, please. So some of the tips that I would give you for those of you who are working towards your designation is really make sure that you are walking that talk. There is a lot of information that needs to be shared throughout the way from the time your patients are in their prenatal visit into the hospital setting and then out into the community. But if you're not actually walking that talk, and by that I mean keeping up on, you know, those standards of care for breastfeeding, which is the whole mission of Baby Friendly, is providing that gold standard of lactation care to all these babies, it's really going to be hard to sustain that movement. What we found is that our patients weren't really always understanding the baby-friendly audit language, and so when they sat down with the assessors, they really felt nervous about speaking with them, and that they really could not recall the teaching that they had received, and you know, prior to the assessors coming out, had told us that they remembered receiving. But when they sat down with the assessors and listened to it in that language, they had a hard time connecting those pieces. So we really wanted to change the way our messages were formatted and give our patients multiple formats. We came up with posters and real visual handouts, which was a big departure from the handouts we had been providing to our patients. We used that same process and developed an actual digital story that we play in our clinics and on our wellness channels as that kind of reminder of this is the continuity of care we need you to expect here in our setting. And we use the same words as baby-friendly so that our families were able to feel a little more familiar when they sat down with the assessors. We started teaching in a way that, included the whys. So, for example, we have this lovely picture here of one of our babies receiving their hearing screen in the room, and we tell our patients, we're doing this so that you and your baby can feed on cue and learn to recognize each other and baby's needs. Those are the same words that we want patients to be able to articulate back. It's very different oftentimes in the way they are used to talking. So being able to remember that in your teaching, we found was real helpful for our patients' recall. If, like us, you're a facility that has satellite clinics, it's important, to also remember that that teaching needs to be extended to those satellite clinics. They are included on your facility data sheet, so any clinic areas, any patient areas where you are giving prenatal education should be on your facility data sheet for Baby Friendly, and those people are potential candidates for interview as well. So make sure that they're getting the same quality and standard of care as those within your primary prenatal care areas. Make sure that you're actually doing audits more frequently, I would recommend, than what, Baby Friendly has kind of a formula depending on how many patients you see as to how many audits they need to do and how many they recommend that you're doing. But we found it more helpful to be doing it more frequently and to have made multiple contacts with our patients throughout the course of their pregnancy. So we actually had nurse managers, myself as the lactation consultant. We had our headquarters baby-friendly consultant that we had contracted with us at the time coming out, our regional or area nurse consultant for our division came out, and all of us were sitting down and talking with our patients and going over this education. Did this happen during your visit today? In a much more frequent standard, to the point where, with some patients, we actually were being told, I already know all of that. Could you guys ask me something different this time? Because they knew the answers. They knew what we were going to ask them. And then also just really make sure that you review each and every chart to make sure that documentation is accurate in there, and that you can find it, because if you can't find it in there and Baby Friendly asks for it, that will not help you pass on your assessment. Next slide, please. So for us, we actually, because we're a smaller hospital, we found that having just a minimum number of patients for our prenatal, vaginal deliveries, and C-section deliveries, that really wasn't enough. And it only took 2 or 3 prenatal patients and only 1 C-section patient to miss a question on interview and not be able to make that criteria. For example, in our first on-site assessment, I think we only had 3 C-section moms that even showed up to be assessed. And when one of them, didn't have all of the right information and documentation, that was enough to drop us to 66% on that particular criteria, and we did not pass that subset. So really make sure that you've got more than enough. I would say easily 2 times the amount of patients. And if you're a small place, or any place actually, because as we all know, obstetrics is very feast or famine. So the day that you have your assessment, you don't know if you're going to have 2 moms on OB or 20 moms on OB sometimes. So the day you have your assessment, make sure you've got those patients kind of on notice and reminded that they could potentially be called. Or one of the things we did, because of our rural nature and the difficulty for many of our families to travel or to receive cell phone signals where they actually live, we found it helpful to throw a party. We had everybody come here. We brought in as many moms as we could and hosted them for the day, and then entertained and cooed over their babies and, had breastfeeding bingo and different
Hey, we seem to have lost the sound. Hello?
Looks like internet lost phone signal.
I can still hear it on the phone.
So this is Anne. I can't. Oh, hello. Is that you again, Antoinette? So can people? I'm on the phone and online, and I cannot hear Antoinette speaking anymore. I don't know if other people can, but I can't. It stopped.
No, she disappeared.
We can't either.
Okay.
And I can't hear either.
I can't either. I hear nothing.
Okay, so I think the connection must have dropped where Antoinette is, out in Shiprock there, so she's probably going to try and call back in. Meanwhile, someone from our team can probably connect with her. I would just like to say, in general, while we're waiting for Antoinette to get back on, that the Indian Health Service did an absolutely outstanding job with Baby Friendly, and all 13 of their federal sites became Baby Friendly designated. And we have been working, I worked with them at that time, and we have, as CHAMPS, work with the tribal sites right now. And just this week, the Chickasaw, which is in Oklahoma, became the 4th out of the 5th. There are 5 tribal sites in the lower 48 states, and of those 5, 4 of them are now Baby Friendly. So there are 18 total sites in the lower 48 that are Indian run. and 17 of them are baby-friendly at this point. So that was a really great achievement on behalf of Indian Health, and we know that the Alaska Native hospitals are working on that now as well. So just sort of very reassuring to know that this can be done by hospitals that don't have great means and have a very high patient-to-provider ratio and also have a really high morbidity rate and high-risk patients with a lot of morbidity and issues around pregnancy and birth. So it's a great achievement for them.
And Anne, this is Kathy. I am unmuted. If you want to answer, maybe do some questions while we wait for Antoinette.
I know that that would be great, Kathy. Most of Antoinette's presentation is probably almost finished, and we didn't have any questions from you. I would love to see some photos of your nuns on their motorbikes. But anyway, go ahead. Why don't people, if they have questions for Kathy, why don't you ask them, and then our team at BMC will keep an eye to see if Antoinette gets back online in the meantime. So go ahead, feel free to ask questions for Kathy while we're here. That probably means you have to unmute people if they're muted, although I don't see that many people muted on here. Thanks.
Yeah, if someone's muted,
Hello?
they can hit #6.
Hello?
Yeah.
I have a question.
Tell me who you are first.
Okay, my name is Jacqueline McCoy, and I'm from Missoula, Montana. And I have a question about the type of interview that is done to the administrators. I understand, anyway, yeah, I'd love to know the type of questions.
Well, it's been my experience. Our CEO could not even say the word breast without blushing. And would remove all breastfeeding pictures from any of my presentations when he first started. So by the time we had the assessment, he was the best. In fact, he got kudos from both assessment teams that he just had a ton of information. They asked, why their facility would want to go to baby-friendly status. What does that mean for moms and babies and the community? How do they do that? Of course, the purchasing department gets asked about the signed contracts for artificial infant milk provision. It's general questions, but by putting together a cheat sheet, they knew that, if this question gets asked, here's how the best way to answer it is. And I'll tell you, they took that ball and ran with it. Our CNO was fabulous. Our CEO was fabulous. Our CFO was fabulous. It was beyond belief when I sat, and it's done as a team. So you are in there during that assessment interview with them. And then after we do the general, then they talk to them one-on-one.
Okay.
And for those of you that are interested, I am happy to share some of those cheat sheets with you.
Oh, that'd be great.
Yes. Did you use the dissemination toolkit to create the cheat sheet?
Sort of. And then I just, especially after we failed that first site assessment, I used what we learned, the feedback that came both from CHAMPS and from Baby Friendly USA. I used that information to really better those cheat sheets. And I found that very helpful. And I think the staff did too. And so I'm going to type my email address into the chat box. And that way, anybody that wants to contact me, and I'm happy to cheerlead and pray for you guys when you're going through your assessment, all that good stuff. Any other questions?
It looks like Antoinette's back online.
Awesome.
Are you there?
Can you hear me?
Yeah, I can hear you.
Okay. Thank you, Kathy, for taking that questions and how appropriate. But I was talking about how difficult it is to get cell phone signal out here. That's exactly what happened. So kind of back to the slide that we have on the screen there, really making sure that, your patients are available, and if they have cell phone signal difficulty, bring them into the hospital, and we were able to set up rooms where we were able to keep them very engaged, and we kept them fed. We just kind of made it very fun for them to entertain, and really promoted it as their community involvement in really helping their community hospital achieve this designation. And we had a really fun time doing that. We found that that was much easier logistically than to try to call patients in. And not all of the patients that we had attending that day were interviewed, but they were there and available, and as Kathy had said earlier, had delivered within at least the last 6 months. So we tried to keep it, really to have the freshest delivery dates. Hello? No, oh my, am I there?
Yes, yes.
Okay, I thought it just kicked me off again. Now I'm going to be paranoid. We'll go on to the next slide, please. I think that the chart review Kathy really talked about. Kind of in turn with what Kathy was just mentioning about having those cheat sheets, we used the same idea, and I don't remember which conference it was that we heard it at, but the idea of stealing shamelessly and sharing freely really, really is helpful to this whole baby-friendly journey. So we were able to pull newsletters that I believe came out of WIC in California, I think originally, and we modified those and used that template to do kind of a countdown newsletter towards our baby-friendly assessment in order to help our staff really be prepared and be kind of ready and be walking these standards of care in anticipation of, this big change, and as well as our baby-friendly assessment. So we did countdowns, we did puzzles with prizes. This one on the screen was around Halloween time, and we gave out like a $5 or $10 gift card to the person who got it correct and turned it in first, or something of that sort. Our staff really gave us feedback that it was helpful to them to have practice with this information, to actually sit down with somebody and be interviewed kind of in a mock assessment setting so that they were ready, to sit down with this stranger assessor, and everybody kind of correlates this to like when Jacob comes through the doors and everybody wants to be scared and run away. Preparing them in this fashion really helped them feel confident. They all walked out knowing that they did awesome, and they were validated on that, when the assessment results came back, and it talked about how wonderful the staff was prepared, how amazing it was that we had a locums pediatrician who had been on staff for less than 2 weeks prior to our assessment, sat down and breezed through that staff audit. It was very helpful to them that everybody who does this care or has hands in this pot of care was able to feel confident. And I would say that you make sure that you have your breast models and your baby dolls ready for the on-site assessment, and that people have practiced handling them and look like they know what they're doing with them, like they don't feel uncomfortable handling that breast model and discussing how they teach hand expression. Next slide, please. And then really just making sure everybody's ready, briefing all of the executive people, the formula purchasing people, briefing everybody beforehand, like Kathy said, and giving them that feedback so that they can really shine when it's their turn to be interviewed by Baby Friendly. We were fortunate because of the way everything rolled out here. We had the support of Indian Health Services, and we also have a lot of statewide support going on. New Mexico Breastfeeding Task Force really was moving huge mountains in terms of getting baby-friendly hospitals designated in our state. The first Indian Health Center, or the first hospital in New Mexico, that was baby-friendly designated was actually part of Indian Health Services, Zuni facility. And for many of the IHS units across the country, they were the first designated facility in their state. So it really helped create this kind of wave of support. And we were able to have, I think we had 20 or 30 people throughout the hospital representing multiple disciplines and departments just there as that show of support when our assessors came in to assess that day, those days. Making sure those binders are ready, just like Kathy said, that they're laid out in a manner that you know them inside and out, and that that second person who's assisting the assessors knows them inside and out, because you want to feel very confident as you're helping them get through the day. I would recommend something that came up for us is making sure not only that you have the receipts for the formula, but we were actually asked to show proof that the credit card used to purchase that formula had been paid. So that statement was paid for, or that balance had been paid for.
And that's part of the baby-friendly assessment.
Yes.
You have to have that. So you're exactly right, Antoinette.
You have to have that, yeah. And we had not had that last piece before that. When it came down to us, originally we were first told just, make sure you have the receipts that you've paid for it. So we brought, at that time, we were buying our formula full price from the local supermarket and paying for that on a credit card. Well, they wanted the next piece, which was that credit card balance got paid off. So we were able to get that because of the wide network of support. I don't think that if I had asked for that in any other setting, I don't think I would have gotten it. But because I had the support of our area consultants and our executive team, they made that receipt happen by the time the assessors came back on day 2. So it was very helpful to have all of those people ready for you. Make sure you get creative with your staffing as well. We found out that, it was helpful for us to have different staff working the inpatient unit on day 1 and day 2. Again, we're a smaller hospital, so our par level for nursing staff is lower. But we had our nurse managers and scheduling people really working on that so that we had almost enough people. We even had to call in a night shift nurse to be assessed early, and then we called in a nurse who was on her day off. And then we even had to have one of our health techs be part of our staff audit because she was part of that teaching, and we were still one shy. So if they can interview anybody who's doing this work, so make sure that you've trained them and prepared them well and that they're feeling ready for the entire assessment. And then I think that's my last slide. Yes, thank you.
Thank you, Antoinette and Kathy. We can take some questions now. We have some time.
And this is Kathy. So I agree with what Antoinette said. We were even more than creative with our staffing. We knew the weaker nurses, and we made sure they were off that day. We knew the really strong ones, and we had them even volunteer to come in for the interviews. So I think that was extremely helpful.
Mm-hmm.
And then another resource for you to pull some information, because we don't steal, we lovingly lift and use it. But Raleigh, North Carolina is a breastfeeding-friendly city. The entire city, they have some absolutely fantastic handouts that you can download online, as long as you don't take their little, I'm sorry, is it Durham? Someplace. I'll have to get that and send it to Anne so that she can share it with everybody. But their entire city is breastfeeding friendly, and they have bus signs, and they have placards in public buildings, and they have big signs by the streets. It's just all kinds of things that you can download and use. Any other questions?
If someone has a question and we're not hearing them, they can hit #6 to unmute. They might have been muted.
Will this be recorded?
Yeah, yep. And the slides are already available on our website, and the recording will be up later this afternoon.
Okay, we just missed the first 15 minutes of Kathy's talk.
Oh, yeah, so they'll be available to download or to watch on YouTube.
Wonderful.
Yeah.
I have a question.
Okay, go ahead.
I was wondering if any of the hospitals had developed an breastfeeding document or the baby-friendly documentation, like chart audit tool that would be easy to capture all elements that are required by the documentation, like on one sheet, so that nurses could do quick chart audits and make sure we're all good.
I have it.
Oh, my goodness. Who's that? Who said that?
Oh, Shannon Scott.
Shannon, what do you use for your EMRs?
We use Centricity CPN.
Okay. I know we use Meditech and Centricity, and you still had to go for the chart audits to 5 or 6 or 7 different places in the EMR to be able to pull all the information.
Yes. I have a CPN documentation, like PowerPoint, that just went out to our staff on HealthStream that they have to review, and then there's an actual paper chart, paper version as well that we have been putting with charts for communication purposes that we use in our audits. So that goes hand in hand with it. I don't know. That's what we're using.
Does that paper chart, which I love that, does that go into the chart and go down to medical records so that it's always available? Or what happens to it after that record leaves the unit?
I keep it, okay, so what we did in our PDSAs is we put it on top of the chart like a Cardex for the nurses to be communicating with. And then when the chart was broken down, it was pulled and put into our, I have it in like to store in our data notebooks with our auditing spreadsheets.
That's an awesome tool.
Yeah.
Would you be willing to share that? Okay, because I'd love to see that.
I'll turn my, let me see if I can get on chat, and I'll put my email address down.
Okay.
Great. Guys, I do see a question that's in the chat here. I'm not sure that anyone's had, asked it. It seems to have gone to our team, but it said that it's expensive to become baby-friendly. And do you feel that it's really necessary to get the designation? You know, it's interesting, especially for some of the small hospitals, it is indeed expensive when you look at the sort of expenditure. You know, you might have only 50 patients a year, and the money that you would have to pay, and you feel you're doing it anyway, and it's a big question. And I know that some of our Alaska hospitals are struggling with that. I mean, it's interesting because Indian Health Service, several of their hospitals are very, very small, less than 1 birth a week, and they still went for it for all their hospitals. I personally feel that from the fairly broad experience we've had working with hospitals, for example, across Mississippi, which is our most recent project, and this webinar is largely with the Mississippi Department of Health, and many of those hospitals are on here. You know, we've really worked intensively with the hospitals in the South, and we found that people think that they're doing baby-friendly practices, and they simply are not doing them. And that's not anyone's fault. It's just the sort of concept of, okay, we're rooming in because the babies are spending most of the time with the moms. Or, you know, we're doing skin to skin, but when you actually look at what they're doing, they're not really doing the full hour. And if you look at the literature and the evidence, it does show that, you know, the more of the steps that are fully implemented, the better the breastfeeding rates get. So I would say that it is worth it. I think it's worth it because it requires everybody in all of the departments to come up to the same standard, that you may have resistant doctors, and as you've heard from our presenters today, you know, eventually, and this is the great piece, eventually those people end up coming on board and they actually do those assessments in the rooms. And sometimes, you know, it can be the requirement at the last minute to get through the test that is what actually makes people finally do the practices that are required, recommended, and evidence-based. So I have yet to come across any hospital, I think, at all, and we must have done well over 100 hospitals, well over, in the experience I've had, that has actually been meeting those standards at the level that they really thought they were, or that I have walked in and said, oh, you don't need to do anything, you're all set. And, you know, we've had a big range of hospitals. Some of them are all great and doing a lot, and some of them are obviously wouldn't even claim that they were all set at the beginning. But I haven't had any hospitals where I've walked in and thought, well, that would be a waste of time to do baby-friendly here. And I think we get you guys who are interested and enthusiastic. We're already preaching to the choir. We're already working with hospitals who want to do this. So, yes, that was my long answer. My short answer is yes, I do think it's worth doing designation. And once you're designated to, you have standards to live up to, and baby-friendly, you know, keeps you in the pathway. So we're about at 1 o'clock, I think. Yes, go ahead, sorry. Go ahead.
I was just going to say, one way to approach it is to talk about marketing and liability. It's much less expensive than a lawsuit for recalled formula that you didn't have a log number for a baby who got sick or died. And marketing, they spend a lot more money than that on marketing. And so by being designated, that's a huge marketing tool.
Right.
Does anyone have the, I know that there's something out there, and I was told about it in one of the other collaboratives, the research on the risk, the formula risk as far as tracking lot numbers and expiration dates digitally or through a scanning system. I know somebody put out, and I want to say, I thought it was Mandel, put out a article regarding risk assessment. Anybody know about that? No? Yes? No?
I don't know. Ann, do you know of that?
We should converse offline. I mean, there are various different things that have been published. We have a lot of those resources on there. I'm not quite sure exactly which one you might be referring to. But, okay. But if you shoot us an email, we'll look into it for you.
Thank you.
I'm sorry, guys. I do have to go because I have another meeting at 1, so I'm going to hang up. But I won't cut off everybody else if other people still have questions and want to stay on. I do need to leave the call. Thanks all. Bye-bye.
Thanks, Ann.
Yeah, so if anyone has any other questions, they can go ahead and ask. I just wanted to let everyone know that we have another webinar next month, June 21st. And Ann will be talking about what will happen next with CHAMPS. We have a new grant starting in the fall, so we're going to kind of talk about that. And then we'll have a new fall schedule coming up after that. So does anyone have any last-minute questions before we finish up this webinar? You can always email us, champsbreastfeed@gmail.com, and we can forward that to any of the speakers. Okay, I guess no one has any other questions. Thanks, everyone, for joining, and thanks to Kathy and Antoinette for presenting. It was really great. All right, we'll talk to everyone later.
Thank you.
Bye. Thanks.
Have a wonderful afternoon. Thank you.
Bye.